Hi, everyone. I'm Katie Sacra, the Family Education and Engagement Liaison for the Global Foundation for Peroxisomal Disorders. Thank you for joining us today, Visual Impairment from Medical Diagnosis to Educational Services. Today, I will serve as your host and for a few minutes as a presenter too. Our presenters today are Ms. Krista Olson, Ms. Marcy Meacham, and Ms. Claire Turbyville. All three are certified teachers of the visually impaired, and all are experienced in working with individuals who have deaf blindness. Additionally, they are skilled in assessment and therapeutic approaches in cortical vision impairment, CVI. Ms. Meacham and Ms. Olson are both technical assistants from the South Carolina Deafblind Project. Ms. Turbyville has spent the last 24 years with Horry County Schools and has received training in deafblindness, including assessment of individuals with multisensory impairments, calendar systems, and haptics. Additionally, Ms. Turbyville has over 17 years of experience working with a deafblind student who has a peroxisomal disorder and happens to be my son. Before we get started, I have a few things to share with everyone. Our presentation, we will not be taking questions and answers live, but we will make sure to take time afterwards. So at any time throughout the webinar, do not hesitate to type a comment or a question in the chat section or the Q&A button on your screen. We know it's often easier to go ahead and submit the questions or comments rather than wait and try to remember. So again, we'll be monitoring throughout the entire webinar. Please don't wait till the end. Go ahead and submit any comments or questions. During the presentation, you'll be asked questions by the presenters through a poll. And I'm going to go ahead and share one with you now. And know that there will be about 30 seconds each time a poll appears on your screen for you to answer. And you will be able to see the answers afterwards, and everything is being collected anonymously. Ms. Krista Olson, Ms. Marcy Meacham, and Ms. Claire Turbyville, thank you for joining us today. And with that, I'm going to turn it over to Krista Olson.
Hi, everybody. I'm Krista Olson. Katie already kind of described my role, so I'm going to go ahead and get started. And I'm looking at our poll right now, and it looks like we have about a little over 50% of professionals who are working with individuals who might have a dual sensory loss. We've got 19% of parents, and then to a child with with deaf blindness, and then 13% are parents to an individual with vision loss. So we've got a good crowd today. So thank you so much for joining us. And then we have 2% of others. So if there's anything, any questions or anything like that, like Katie said, just go ahead and put them in the chat pod for us. And I believe we have one more poll to go up before we get started. And this one is asking if your child or you have ever received vision services from a teacher of the visually impaired. So we've got about 40% of people saying they are currently receiving services, about 9% saying that they no longer receive services, 27% they have never received the services, 9% not from a TBI, but they have gotten services, and then 18% I don't know. So hopefully we'll be able to cover some information and clarify some things and kind of talk about the process as we go through this. Again, feel free to comment and ask questions as we go. I know that we have a few countries represented on the call, and so if what we talk about is very US specific, feel free to comment or put anything that may be unique to your country in the chat pod. We're happy to kind of have that extra information. But in terms of just the process and some of the information itself, it should be pretty universal. So I'm going to kick some things off with just talking about just the start of the process, which is the medical diagnosis. And it's important to know that once we start this process that the doctors really look at the medical component. So an ophthalmologist or an optometrist, both who do eye exams. So you may see an optometrist, those are ones that are trained to do more of the glasses and things like that. An ophthalmologist can do surgery, prescribe medication, things like that. They're looking primarily at your eye health. So they're not looking necessarily at functioning. They want to know if the eye is, how healthy it is, if the pressure is okay, what the acuity is, all of that fun stuff. There are something called low vision specialists, and these are optometrists as well, but they are trained specifically in people who may already have a visual impairment and working with them. So they may get some additional information from an eye exam or give you some additional information or use different testing techniques. When we look at what an eye report contains, so once you get that medical diagnosis and you have that piece of paper in your hand that you are going to hand into the professionals in the school system, they usually have the diagnosis and the etiology. So how did this come about and what is it called? They'll usually include visual acuity, corrected and uncorrected. So this means what the child's visual acuity is with or without glasses. A lot of the times we see the number 20/20, but we don't ever really hear what that means. And so 20/20 means that the distance that they measure at is a standard distance. So what they see at 20 feet is what the average person sees at 20 feet. So if you see a diagnosis of 2200, think of what you see if you have good vision at 200 feet where it starts to get a little fuzzy. That's what somebody who has at 2200, what they're seeing at 20 feet. So the higher the number on the bottom, the worse the vision typically. So 2800 means what you see at 800 feet, they're seeing at 20. The next thing are visual fields. And so this may be, this can be tested in several ways, but this is going to talk about losing kind of fields of vision, whether it comes from the peripheral or if you're losing it centrally, if you have any kind of macular degeneration or blind spots as a result of some retinal degeneration. Eye pressure is typically related to glaucoma conditions, and that's the pressure of the inside of the eye. If you've ever gone to the eye doctor, that's where they usually blow that puff of air into your eye. Although they're changing that now and they're starting to do like a blue light that I think comes a little bit closer. And then some specialists will have recommendations. And so it may be that, they qualify for services or that they need to sit in a specific spot. A low vision optometrist may include a little bit more. So they may talk about what the lighting looks like, where seating would be best. They may recommend a slant board or a magnifier or a monocular. So it's really dependent upon that doctor. And just really quickly for our students who are or aren't communicating proficiently, they may do certain things like teller acuity cards. So if you're looking for an acuity or a measurement, they may have different lines of different varying thicknesses, and they see if the child kind of attends to those. Or you may see something called CF, which is counts fingers. It's a very broad way of getting an acuity, not very clear. You also may see those symbols like a house, an apple, those kinds of things. And those are other ways for students who are maybe non-readers or younger children to do an acuity test. And you may also see other things like LP, which means light perception. The child only sees light. Or you may see NLP, which means no light perception. So we're looking at what we would call total blindness. So just kind of an idea of what those medical diagnoses look like. I'm going to move on really quickly, to the referral process. And so when you're looking, once you have that medical diagnosis, the next component to getting your educational services is getting a referral for those services. So this happens, at least in the younger years, in one of two ways. A doctor will refer you to early intervention or educational services, so they'll provide that information to the school or whatever early intervention entity is in your state. And a parent can also reach out to the doctor or the local school system to get information for services. So if you have some concerns about your child, you can contact the school system. This also can differ for an older child. So you may see if your child does not have a diagnosis, but they do a vision screening in school. Sometimes they'll reach out to the parents for more information, and that can happen, or they'll go through what they call a child find process, where most school systems have a process of identifying kids that may need to be assessed. Once that referral has been made, then they'll start to assess the needs of the child and see if they need services. No matter what, the need for educational services has to be based on, it's usually two criteria. So they have to meet the medical need and they have to meet the educational need. Having said that, the Department of Special Education has put some new rulings out that say, if a child doesn't meet medical need, but they still have educational need, they may still qualify for services. So that's just something new that came out about last year, I want to say, just to keep an eye out for, because I know some of our kids don't meet the traditional criteria of visual impairment, but they still have an impact. So it's just a good little thing to know, an extra bit of information. I'm going to hand that over to Claire.
Okay. All right, are we going to do a poll?
Yes, so we have a poll and it's asking if your child has ever received a functional vision assessment because we are going to move into that a little bit more soon. So we have 33% who have, as of right now, sorry, I'll give it a second. And I apologize for the noise in my background. I have a little one in the other room. So we have 29% who have had functional vision one time, 14% who have never had one, and 57% who don't know if they've had one or not. And Claire, you are on.
Okay. Well, my name is Claire Turbeville, and as Katie introduced me, I am a teacher of the visually impaired. And as Krista just shared, once the referral is made, in order to determine the eligibility for services for a student with a visual impairment, the TVI now must consider the diagnosis and how the student functions with that diagnosis. So we will first review the I report. The I report provides the medical condition and, what does it mean? It could be an ocular condition such as optic nerve atrophy, nystagmus, retinitis pigmentosus, or even cortical visual impairment, or a combination of CVI plus something else. This also lets me know that I can research the physical characteristics, the medical treatment, and any possible causes of the condition. So based on the diagnosis now, I'm able to ask and research some other questions, like what are the resulting effects of the eye condition on the student's vision? How might they typically function based on this condition? This provides me with possible behaviors that they may display given a certain condition, and also helps to guide parental interview questions I might have, like what are some of your child's favorite toys? What do they look like? What do they feel like? How do they interact with them? And when do they seem to be more alert or attentive during the day? This all helps me with knowing what kind of materials I may need to use with this student and what time of the day would be best for assessing and observing the student. The next, what are the general adaptations and educational considerations, such as lighting, color, contrast, positioning, or best viewing? Would there possibly be orientation and mobility considerations for this individual if they had a diagnosis of a reduced visual field or depth perception issues? And then next slide. Okay, here I also use the words typical and general because I know that every child is different and unique in the way and how they use their vision. No two people with the same diagnosis may function the same with that diagnosis, and there are many factors that are relevant to that, such as the use of vision can be related to their cognitive abilities, previous experiences, a stable or progressive condition, attention and distractibility, environmental factors, and any physical condition and health. And we know that all of these things can affect vision and how a person functions minute to minute and sometimes day to day. And we see that also a lot with students who are cortically visually impaired. So really, students who have multiple disabilities, visual impairments, including deaf blindness, we know that they function atypical. They don't necessarily fit in a textbook description with the visual impairment. Okay. When working with students with visual impairments, multiple disabilities, and deaf blindness, we need to know the how, when, and where the student can see and use their vision in a variety of settings. This is how the student functions. So as Krista said, we have the medical component, the diagnosis. Now we need to know how that student functions and how it's going to affect their educational access and performance. So some of the things we would be looking at are what are their visual skills and abilities for performing a task, such as being able to track and follow. Do they turn their head as they reach for objects? Do they have depth perception issues? What are their also not only is the visual component, their ability is very important, but we also need to know more about the student, not just the vision, but everything else about them because it does affect vision. So now we're going to look at the primary sensory modalities for learning, such as if they're using vision or not. Do they also use auditory senses, tactually senses as well? Or do they use a combination of them or not? What is their best positioning for learning? Do they use their vision best and learn best when they're in a prone position, when they're reclined, or maybe even sidelined? What are their sensory, are there any sensory issues such as auditory or tactile defensiveness? Because sometimes the environment can just be overstimulating with loud noises, or we don't want to force a child to touch or interact with something that they don't like or that would disturb them. Also, what time of day are they most alert or tired? And as I had described earlier, this is a question I would ask parents, but also in the school setting with the classroom teachers. You know, have they just had a big meal and after lunch is not a good time because they're full and tired? How does the environment affect their learning? Again, we talk about noise levels, but we also want to consider with the diagnosis, is visual clutter going to be too much or too much movement in the room that's going to cause a lot of distractibility? And then what teaching strategies and associated materials in the appropriate media are accessible to them, and how can they be used for learning? So if an individual student has certain sensory modalities that they use best, or in a combination such as vision, tactile senses, and hearing are all primarily how they would learn something, we would want to critique their curriculum or their program to match that, and then match strategies and materials with that so that concept development can be optimal for them. On the next slide, excuse me. So basically with all the things that I just listed for you when it comes to their vision and sensory modalities in the environment, the team needs to know how the student functions as a whole person. So really we're taking a holistic approach to assessing this child so that we can learn what is the optimal conditions for this child to learn. And when we do that, we're able to develop a student-centered learning plan that includes appropriate accommodations and modifications, appropriate goals, the ability to progress monitor and review the results with the team members, and adjust instruction and strategies as needed. All of these components are very important when developing the IEP plan for the child and being able to implement it successfully. Because the overall goal is to increase the student's participation within their environment and their conceptual learning, and for every student to become an active participant and contributing member of society. Next, what you asked, what do we do after this? Well, then we move on to assessment. We're going to go more into depth that next, I believe, with Krista.
Hi again, and we are going to talk about assessment. And before we move on to that, I'm just going to give a really quick story because I know I learned well from that kind of idea. But in terms of medical versus the functional, I had a student that I went to the ophthalmologist with, and she had optic nerve pallor, which is a very means the information travels slowly back to her brain. And she was originally diagnosed as blind, but vision had gotten better over time. And I watched the doctor tell this mom that her vision was the same and still was not very functional, at the same time as mom was holding a Cheerio in her hand and moving it across planes, and her daughter was watching it the entire time. So when we talk about diagnosis versus function, that's a perfect example of the diagnosis may say the health of the eye, but when we're looking at the function, our children may very well be using their vision in a very different way. And may be able to use what they have more efficiently than what the medical report says. So that's why this part is so important. So when we look at assessment for vision services, we have 3 areas that we assess in terms of the area of vision alone. The first is the functional vision assessment, and this is going to be your main component. This is your general visual needs of the child. We're going to go into a little bit more detail with this, but a lot of what Claire was saying, how do they interact within their environment using their vision? How is it everyday activities? How are those happening? And then the second piece is that learning media assessment, which Claire also touched on a little bit, which is which modalities are they using? How do they best access information in their environment? And it's important to note that that might not just be one way, it may be several ways. The third component is something unique to vision, and that's the expanded core curriculum. And these are everyday skills and information that might be missed incidentally. And incidental learning is basically the information that we learn without actually having to be taught it. So learning how to do the dishes by watching your parents do them every day. So by the time you turn whatever age a family deems appropriate for the child to do the dishes, they don't have to be taught those things because they've seen it done over and over again. So the expanded core curriculum covers all of those areas that we might miss that way. Legally, every 3 years, the functional vision and the learning media assessment, also referred to as the FBA and LMA, are to be done every 3 years. The expanded core is not necessarily federally mandated, but it is part of what we should be doing when we assess as a teacher of the visually impaired. You can request that these assessments be updated more frequently. And you may do that if you've noticed a change in your child's vision, if there's been a medical change, if the environment is changing. So there could be quite a few reasons why you might request them more frequently. If you have a degenerative condition, you may want to monitor that more regularly. So a parent does have the right to ask for an assessment with, earlier than that 3 years if it hasn't been done. Concerns. So the next component that we're going to move into is that functional vision assessment. So this is that more general component. And this is going to cover things like near and distance acuity, but it's not necessarily tested the way that they would test it in a doctor's office. So we may look at things like, can your child, if they have visual acuity to do so, are they reading food labels or price tags? That might be something that we look at for near distance or for near acuity. And then we may look at, can they read a sign in the grocery store for distance acuity? So we have a lot of different ways that we're going to look at that in terms of everyday functioning. And we may use some different tools for that as well. And we may use some traditional tools as well. A teacher of the visually impaired will also look at eye motility. So that's basically, are the eyes basically both looking centrally at the same time and following each other? Or do we have one that's kind of maybe turning out or turning in? So possibly a weaker eye or not, and different strategies for that. Do we have a blink reflex and a pupillary response? So just some basic information, because that also gives us some information about lighting needs when we look at a pupillary response. Then we're going to look at visual fields, again, not tested in a medical way. We do usually what are called confrontation fields. So we may bring an object from all angles and see when that student physically reacts or says that they see the item. Color vision is another area that we would test, and that's something that we do in a variety of ways depending on the communication needs or level of the child. So it could be something as simple as matching colors. So it may be we show them a red one and see if they can find a red one and can differentiate the colors. It may be naming colors. It may just be the perception of different colors. And so we're going to look at a variety of ways to test that as well. Depth perception looks at both, can a child reach for an object without overreaching for it or underreaching for it, or maybe step off of a curb and notice that drop off. And a lot of the times if we have one eye that's more effective than the other, or if we have an eye that is in total blindness where the other has some vision, we're going to see some depth perception issues. A lot of our kids learn how to accommodate for that, but we can still usually notice the little things where they're reaching a little further than they need to and then maybe raking back. Contrast needs. So do we need white on black versus black on white? Can they see gray print on white, or lighter things? Do we need to make sure everything is really kind of bold for them? So we're going to look at those kinds of things. Do we have an eye preference? And this can be really important in terms of positioning materials. So do we have, does the child prefer their right eye? Is that their stronger eye? There are cases where the eye with the worst acuity is the one that they prefer to use. And so we have to make sure that we're meeting them where their needs are. Light sensitivity. I talked a little bit about this with pupil area response, but do they need some extra time to adjust to lighting changes if they go outside or if they walk into a dark room? If being outside in that bright light, is it too much? For children who have albinism, they're going to be very, very sensitive to light. And so we may need to look at wearing glasses that have some tint in them or a hat indoors if the lighting is something that bothers them. Fixation and shift of gaze, tracking and scanning is all kind of movement of the eye. So can they actually fixate on one item? Do they have a straight fixation? For our kids who have cortical visual impairment, that fixation can be very brief. Can they change vision from one area to another quickly? Can they track across a line? Do we have any issues in terms of that kind of motility? A lot of the times we'll see if a child physically isn't crossing midline, we'll also see that within the vision. So where maybe they're tracking from left to right and we see like a jump before we get over here to the right, because that motion's not smooth yet. Figure ground perception is being able to notice something against a different background. So if we dropped a penny on a very busy brown floor, would they be able to pick it up? Can they find things in their area? Can they differentiate, like within a picture, if it's a line drawing, the background from the foreground? These tests are always conducted by a teacher of the visually impaired. They are the ones who are trained to do this kind of testing. It can be done a variety of ways. So there may be direct assessment, there may be observation. For our children who maybe don't have proficient communication methods, it may be through interview with people who work with them, including their family. And if the child has a cortical visual diagnosis, the CVI range, which we might have mentioned, I think, back in the last webinar, can serve as the functional vision assessment tool for that child, and in most cases should serve as that tool. The next area is the learning media assessment. And so this looks at the preferred sensory channel. So a typical learning media assessment looks at whether the child prefers visual stimuli, auditory stimuli, and tactile. And we usually get a primary and a secondary. So depending on the child, like if the child is a Braille reader, we may say their primary is tactile, and then we also do auditory as their secondary. So, we may work on both of those skills. So for children that have more complex needs, we're going to look at a broader sense of this area. And so we're going to look at all the sensory channels. We're going to look at not only those three primary ones, but also taste, smell, and movement. We're going to add to those. Are these ways that they can gain information and help them kind of have a little bit more control over their world, be a more active participant in their daily routines? This also can be done through interview and direct assessment and observation. So there are quite a few tools that exist to test this for children. I'm a big fan of the sensory learning kit, which is pictured on the bottom right there, but there's every move counts. There's a lot of different ways. Teachers are going to choose what assessment they use based on the needs of the child. So if the child is a print reader and has established language and communication, we may be looking at the more traditional learning media assessment book, there's an actual book titled Learning Media Assessment. If the child has additional needs, we may be looking at some of these other tools like the sensory learning kit that kind of gives us a broader overview. This is super useful because it helps us choose meaningful materials for the child when we're programming their educational needs and their goals. And so we're going to use materials that they can access and that they want to access to increase understanding and participation. That next area is the expanded core curriculum. And I had mentioned these are the areas that we might not learn through incidental learning. So just by regular observation. So compensatory access talks about your academic access. So, is the child a print reader? Are they learning things through tactile means? But it also looks at things like scheduling. Can they manage, their daily schedule? So all of those kind of typical academic access areas. The next one is sensory efficiency. So this is how they're using their vision within their environment. So can they see things at a long distance? Do they need a tool for that? Do we need to put things upright and, on a slant board for them to be able to see it better? So how exactly are they using their senses in their environment? And that goes to using tactile means and auditory means. So it kind of looks at all of those areas. assistive technology. So that could be as simple as a braille writer and paper is considered assistive technology, as is a pen or a pencil, but also things that are a little bit more, complex, like a communication app if they need it, or a magnifier to see print that's smaller than, what they can access with their vision, or a closed circuit television, so a CCTV where they put paper under it and it would magnify it on a big screen. It also looks at voice output devices, and so, or like screen readers. So if you're on the internet and there's something that actually reads everything out loud to somebody who can't access that visually. The next area is career education. And I think a lot of people think this goes for older children, but this really starts as young as possible. And when you think about preschool rooms that do sections on the community helpers, that's career education. So all of those things are career exposure. Even just going to the grocery store is career education in terms of exposure to what different jobs are out in the community. Independent living skills covers eating, toileting, getting dressed, making appointments, that kind of thing, all kind of fall under that umbrella. Orientation and mobility refers to where you are in space and how you travel. And there are certified teachers that specifically work in that area. And so a teacher of the visually impaired may do a screening tool if they're not certified in that area, and then pass that component of the assessment off to an orientation and mobility instructor. Self-determination is your child's ability to advocate for themselves or do things for themselves. And so we look specifically at, do they initiate things independently? Do they speak up for themselves? Do they ask for what they need? Those are all self-determination skills. Social skills, how do they interact with other people? And is there anything that we need to do to help facilitate that interaction or to teach them how to do that more independently? Recreation and leisure, again, something that all kids get exposure to from the beginning, but our students might need some more direct learning that goes along with that. And there are a variety of tools that can assess these needs. And so they range from checklists from text to school from the blind and visually impaired. There's a unique learning skills for kids that might have more complex needs. So I know South Carolina, we just redid our form, and we have some checklists that kind of cover each of these areas to see where we need to meet needs for students. So there's a lot of different ways that you can do this. A lot of it is a little bit of experience and observation, especially for our kids that might not be primed for direct assessment. We may be observing them within their environments to see how they're doing, all of those things. I'm going to pass this off again to Claire.
Okay, this is Claire again, and now I'm going to talk about the type and amount of services. First off, we have supplemental services. These are services a child needs to participate with non-disabled children in the regular classroom and in other educated related settings. These services may include modifications to the curriculum or the classroom environment, extended time to complete tasks, assistive technology devices, and any other accommodations to allow their regular classroom participation. Next is related services. Services a child with a disability needs in order to benefit from special education. And these are often the specific services provided directly to the child, such as vision, speech therapy, occupational therapy, physical therapy, or orientation and mobility. And vision services can either be one or both. Vision services can be a standalone service if the student has no other disability. So then it becomes special ed, and we're providing supplemental services for that individual to be in the regular classroom with their same age appropriate peers. The related services we can also do for the student who is receiving special education services, and they also need that more intense, direct, specific instruction. And the next slide.
And Claire, really quickly before we move on, we have a poll. And this is what type of service does your child currently receive? And our choices are direct service, consultation or indirect, collaboration, orientation and mobility, a combination of any of these services, and I don't know. And we have 57% saying a combination of those services and 43% unknown. And that's pretty standard. You're usually going to see a combination of the service delivery models.
Okay. For each student who's blind and visually impaired, they have their own unique learning needs, and their type of service should reflect their needs for specialized instruction at any specific time in their development, which it can change over time, especially if they're progressing through their education, their services may change. So first we have here is direct services. Direct instruction is appropriate when a student has a short or long-term educational need that can only be met by a specialist in that area. Direct instruction should be considered, especially when a individual needs instruction like with Braille or some kind of communication system or tactile system that will allow them to have access to their education. And the assessments that have been conducted will help reveal what these needs are. And they also, the instructional activities can vary by setting as well as individual need. So direct services can take place within the classroom environment where the specialist may come in and work directly with the student in a classroom environment, or they could possibly be pulled out where it would be best away from distractions where that student could learn best a specific skill at the time. Now, without instruction in these needed skills, such as the expanded core curriculum, students with disabilities cannot access the standard curriculum or engage in daily activities that are basic to their own well-being. So it's very important that they get these specialized instructions based on the assessment needs and that are shown through the expanded core curriculum. Areas, again, here I've listed the areas of the expanded core curriculum. Even Krista's already gone over those for you. On the next slide. After direct instruction, we also have indirect or a consultation service. This is where the student requires a minimal or no direct services from a specialist. The services provided to the adults that work with the student on behalf of the student and for the educational needs of the student. When providing indirect consultation services, the services should include observation of the student in a variety of contexts. And this can be within the classroom, the home, if possible, if your district allows you a teacher to go into the home, with other related service providers to go and work with them or observe them working with the student. And also out in the community, if the student is already in a transitional phase and is working out in the community or even in school-based work activities. It's important to provide suggestions on materials, environmental and curriculum adaptations that may be needed, given the setting that the student's working in, and have frequent contact with the student so you're familiar with the student and their current needs. That's one of the things that I see with a indirect service or a consultation service. Sometimes service providers don't spend enough time getting to know the student themselves and really knowing, not past that first initial evaluation or assessment, the student will change, and sometimes they don't keep up with that enough. So I believe that frequent contact with the student and observing the student is needed. You have frequent contact with the teachers, paraprofessionals, and therapists to support their goals and objectives and help them understand the student's visual needs. So this comes into just providing a lot of training and ongoing communication so that everyone working with the student understands how the student functions and what their visual needs are, what their sensory needs are, and that way you're better able to monitor and adjust as you go. And that way you're not waiting till that end of the year or whenever you have that annual IEP meeting and you say, well, this isn't working, and you've just lost 6 to 8 months of very valuable time. But if you have that frequent contact with everybody involved, then you know when things need to be readdressed and if a meeting or change needs to be made sooner than the annual IEP meeting. Next slide. So direct instruction and indirect consultation services can be provided separately or in a combination depending on the student's need and the need for the family, teacher, and staff support. I have a picture here of our host, Katie Sacra's son, TJ. He is my student, and we have worked together for 17 years. And an example of how services can work in a combination, I work weekly giving direct services with TJ. I see him directly once a week. I also consult with his teacher and his deafblind intervener weekly. We are constantly discussing how he's doing each week and on the things that I work with, reviewing that with them after I get finished, and them letting me know how using whatever strategies we've put in place in the classroom, how those are going. But not only do I do the direct instruction, and that's a consultation with the classroom teacher and those working with him, I also do a lot of observations with this student. He does school-based work as well as community job site training. So I go to those frequently, anywhere from once to twice a month, and I just do observations, and I'm taking down data on what he's doing and how he's doing it. This also gives me provides an opportunity for me to support the deafblind intervener, where I can help support her that what she's doing is correct. She's giving good haptics. She's providing good communication with whatever activity he's involved in, and also gives the opportunity for other people, if they needed to come and watch me work with him, and I can instruct and help them to understand his vision better. Then, so you can see that it can be really collaborative there, in just a combination of the direct and consultative services. Whatever he needs, we try to provide. The amount of service, the time that the service provider spends with the student, should be based on the time required to meet the special education goals and identified in the IEP plan. And there are several tools that we have listed here that teachers of the visually impaired can use in order to determine what is the best and most needed amount of time for the student. And I will let Marcy discuss those with you.
Hi, this is Marcy. Thank you, Claire. That summary was wonderful. We have several different ways of determining the amount of service. And of course, the IEP needs are going to determine the amount of service that the child gets, along with the IEP team agreeing to it. And there's several different tools that can help a TVI and the IEP team determine the amount of service that the TVI will provide to the student. There's one called the Michigan Severity Scale, and there's two, Michigan Severity Scale, and the one I really want to point out is the one that has Michigan Severity Scale with additional disabilities. And that just looks at the child's vision, their needs, if they're going through transition, if they have additional issues like motoric, communication needs, and it weights them, and then you tally it up, and it helps you come to a range of the amount of like maybe minutes per week or minutes per month, whether you know, what kind of service they need. And then there's also the Texas School for the Blind and Visually Impaired visit. And that's a mouthful. And that is the Vision Impairment Scale of Service Intensity of Texas, and the visit. And that's on the TSBVI website. And we have these resources listed on a separate handout for later. And that's a bit more involved type of instrument to use, but it's also gives a really good range. And then additionally, we have the QPVI, and that's Quality Programs for the Visually Impaired. And that also is on the Texas School for the Blind and Visually Impaired website. And if you just Google administrative toolbox, it will give you the entire, a range of different case load analysis for TVIs in a school district, as well as ways to determine how much service or how many minutes or direct instruction a student will get.
And this is Krista. I just want to add this again, as Marcy and Claire both said, it can be a team decision in terms of it needs to be a team discussion. But specifically with the one that I'm most familiar with is the Michigan, there are pieces of it to where a student may come out as consultation when you fill out all the boxes, but there are exceptions. And so there's places in that tool to say, but this child is transitioning to a new environment, or we have a degenerative condition or something, you know, they have a medical situation going on that may necessitate the need for more or less service. And so it's also flexible in the sense that I've had students who are transitioning to a new place and I may increase their service for a period of time and then go to a more typical schedule throughout the school year and then up it again at the end of the year. So there's fluidity within this process to meet the child's needs and the team's needs. So some of that also could be training for the staff as part of consultation that may increase services in the very beginning of the year and then reduce through the rest of the year unless it's needed. So I just wanted to add that little component in. And we're up to Marcy.
Okay, now we're going to talk about VI resources, visual impairment resources, assistive tech, and materials. And we're going to go through this rather quickly because we have an additional handout available. So the first one, of course, is American Printing House for the Blind. And here in the United States, the APH has been federally funded, and children who are eligible get registered by their teacher of the visually impaired. Sometimes it's an early intervention specialist who's allowed to do it as well. And they register through APH, and there are a plethora of materials, tons of materials that are available free with what we call quota funds, those federal funds. And there's an online catalog as well as a way to go and order a paper catalog. There's tons of resources. There's a specific section just on cortical visual impairment, one for the family. They have blogs. They talk about virtual summer camp activities now in the time of coronavirus, and they just have a lot of really amazing supports there. And here are some of the common things that you often see that are free with quota funds. We have a mini light box that's used for children to help them focus, provide a backlit surface. You can get color overlays that you see here in the middle, different colors, different shapes on those that you can put on them. There's also, you can order some of the different kits. I think they have mini light box or light box kit 1, 2, and 3, and they go from like basic shapes all the way up to sorting and identifying small pictures. And then over here on the far right, you see the Joy Player, which is a wonderful device, and I think Katie Sacra's son has one that Claire has ordered for him, and it plays music. You can hit different switches, teach the student how to use it. It's just a great way of allowing them to maybe enjoy a book on an MP3 recording or music. Nice choice making too. And then down here, we have some adaptive aids commercial. I just listed one. There's another one called Maxi Aids. This is from Independent Living. If you have an older child or a child who loves to cook, they have different types of cooking materials, timers, just a plethora of measuring cups, mixing bowls that won't slide and have high contrast. Just some real fun things there. I love to go shopping there. And then also some homemade ones. Over here you see a little boy. This is from the active learning site that we may talk about later if we have time. He has what's called a buncher, which allows him, I don't know if you can see it very well, he has a spoon loaded with something that he's getting ready to eat. And it's a homemade buncher made with elastic band around his hand, and it helps him grasp a spoon since he's not able to do that, something that you can make on the active learning website. And then over here on the right, which is something a lot of us use, is just a 3-ring binder. If you don't have time, or you can't find, or you haven't ordered or gotten one off quota funds, you can make a slant board just using a big 3-ring binder. Just a couple of examples. And then assistive technology, and Claire's got some amazing pictures later on of students using a variety of these things. There's CCTVs, electronic video magnifiers, which the lady on the right is using, and Braille note takers, refreshable Braille displays, which you see this little girl down here is using. It looks like an iPad with a refreshable Braille display. Just some wonderful things that allow our students to access things. And then also the good old Perkins manual Braille writer. That looks like one of the old-fashioned sturdy ones. They weigh about 20 pounds. Indestructible. Great feedback too. And over here on the right, you see a young man who is interacting with a Braille note taker. And then down on the bottom, this is something fairly new. It's for very young children to explore. I think it's called a Busy Brailer or Busy Braille. And it's almost like an interactive toy and starts to teach some of the Braille writing, Braille scribbling. Just and the Perkins Brailer and the Busy Bee or Busy Brailer, those are free with quota funds. And then also some different VI materials. Here you see from the active learning website, a little room with a resonance board. The resonance board is an amazing piece of equipment that many of our children with visual impairments and additional disabilities can use to explore, especially if they're not reaching out and grasping yet, teaching them things like that. And also the active learning, the little room right there. It's just wonderful. That one looks like it's a homemade one. And then over here on the right is a picture of a homemade position board that I believe they also have the directions on how to make that on the active learning website. And this one is just a pegboard, and it's got duct tape around the sides to protect the sharp edges, protect little hands from sharp edges, attached with elastic bands and all sorts of things to feel, interact, shake, grab, pull. And also we can't stop talking about VI materials without talking about object calendar systems. And the one on the left is an anticipation object calendar system. First we do this, and then we put it in the all done basket. And those two baskets are very different from each other. In case the child can't see that well, they may be able to feel the difference of first I do this, then I put it in the all done box or basket. And then over on the right is one that's on an all-in-one board, which again is free with quota funds. And this looks like perhaps an activity or a morning calendar. It's got, it looks like a box of Cheerios. It's got something about tactile exploration, maybe. The next object is, it has a CD, which may mean music. And then it also has a spoon on the end. And that child would grab that first thing, do that activity, put in an all done, and then go to the next one. And then here's just a few other things. We've got various tactile vests. One's homemade, one I believe is commercial, that they're attached with Velcro or Veltex material. And, or some of them are sewn on with little binder clips. And the good thing about that is that you can take those things off and wash them too. And those are for those kids who hold their hands up or aren't really exploring very much yet. And then over on the far right, there is a box. It looks almost like one of the activity boxes that you can get from APH. And it's got just a ton of different balls, smooth balls, bumpy balls, big balls, little balls, heavy balls, light balls, and just another exploration activity. And then over on the left on this next slide, we have a triangle board, a little boy with a pegboard painted black, different materials attached to it that he's grabbing, interacting, shaking, exploring. Things have different weight, tactile components to it. We have a tactile belt. I think you can get those from Target. With different things hanging from them, and then also an SPG board from Active Learning. You can make one. This is a homemade one, and it's just different things that you can scratch or grab, or they call it SPG, which is scratch, position, or grab board. Okay.
Okay, this is Claire again. Here we're going to be talking about implementation of services and how can communication and training for the team of the students' learning styles and needs best be met. Well, there are many methods depending on what works best for your team. And every team looks different, of course. So, and not everybody can get together at one time in one place to learn about a student, what their needs are, and what are the communication needs and the best way to communicate with the student. So there's many ways you can do that. And we've got them listed out here for you. We've got handouts, videos of the student themselves, engaging in routines and activities so that another individual or related service provider can see exactly how the student does something. Also webinars, learning from other people on specific methods or strategies of working with the population of our students. Presentations such as just presenting in the classroom or to the staff at a school who has never had maybe a deaf-blind individual in their school. You may present at a teacher's meeting to help educate them as well, so the school knows how to interact with that student when they're moving around within the school. Related service providers should read the entire IEP and reports. And I find that this is a very important aspect because in my years of teaching, I have found that I do have at times related service providers asking me questions about a student that we share that it's all written out in their IEP very explicitly. So I don't mind repeating those things and sharing and re-educating, but I think it's important for all team members that work directly with a student or provide services to a student, no matter what that service looks like, that they should have a good understanding of what the IEP says. Also, co-treatment and service between providers. Co-treatment is very fun and exciting to do. And I have done that before as a teacher of the visually impaired. I have worked with our O&M instructor to co-treat with a student. I have worked with SLPs as well. And I feel that it's very important that as we're doing that, we're learning from each other and we're learning about how other people interact with the student and how the student can interact with other people. So co-treatment with services between providers, I feel is a very essential part of learning more about our students, and also being able to use Google Drive to share information. The team that I work on with my student TJ, who is a student with deaf blindness, we use a Google Drive. And with that, we are able to share videos and documents between team members as well as the family. In videos, and we find that's very exciting because sometimes the parent will post videos of things that the student has done at home or while they were away from home, and we're able to see how that student's able to interact in different environments that are outside the educational system, or just where we're not if they go to grandma and granddad's house. So the use of Google Drive for sharing information is also another way that you can do it. Next slide.
And this is Krista again. So I'm going to talk about a little bit more about the implementation of services. And one of the areas that we look at, especially when we're looking at collaboration and consultation services, or even when we're looking at family services for a younger child who's in early intervention, is role release. And so when we think about our kids, they may see 10 different providers between private and school therapy and everything else going on. There may be a lot of people coming in and out. And so what role release really refers to is somebody who has specific expertise, maybe working with the child and then showing everybody else on the team, or maybe one main person. So in early intervention, that typically is a family member, how to do those things so that they're releasing that role as the specialist to show them that they can reinforce and do those activities all the time. Because as we talked about with vision services, when we choose type and amount of service, it may be that your child's seeing once a week, or sometimes even once a month, or maybe quarterly. And that means that if we're only having one person responsible for that skill, that child is only getting it once a week, once a month, once a quarter, depending on their service delivery model. And so basically this allows them to get that skill all the time because the service providers are providing that information to each other. So we're not teaching these things in isolation because, especially for our kiddos, we know that we need that consistency to generalize. The same thing with shared goals. And so I think anybody who's got a child that has an IEP can become overwhelmed by the amount of goals that could be listed on the IEP. And so when the professionals look at these goals and they say, well, I can work on this area and you can work on this area, but we can share that goal and kind of meet in the middle here, even with that co-treatment that Claire had talked about. I know I did that often as a TBI. We are reducing the need for that goal overload. And we're also making sure that it's getting with multiple people across multiple settings so that they can generalize it. And we're kind of helping prioritize what those goals are also, because again, we can get bogged down in, well, we need to work on feeding and we need to work on shoe tying and then we need to work on reading and then we need to work on math. And it's like, okay, well, how can we work on some of those things? You know, if the child's not isolating their fingers, can we add that into a shoe tying goal so that we can work on those skills together? It doesn't have to happen in little silos. It should really be happening because your child is not made of silos. They're one person. So we want to make sure that those skills are getting across all areas and people.
Okay, so here we've got a couple of pictures of accommodations that would help you with implementing your plan for your student. Here on the left, this is just a picture of light covers. They're called whisper white shades that you can put over the lights. They help to reduce glare within the classroom environment, because we know a lot of our school classrooms are set up with linoleum floors, white cinder block walls, and high ceilings with fluorescent lighting, which really just bounces a lot of reflective light everywhere. So a good many students with visual impairments need to have that glare controlled or reduced for them. And one way is through light shades. The picture on the right is a object card calendar system on the wall. And we wanted to show you this to show you the high contrast and the ability to reduce the clutter and to provide the tactile simplicity for these objects. That will make it easier on the student for identification and learning of a calendar system. Here we have tactile accommodations and visual awareness accommodations. You can use red duct tape for marking handles and cabinets in a kitchen area or anywhere in the classroom or in the home environment as well. If you'll notice on the microwave handle, there's some red duct tape that provides the visual as well as the tactile ability for the individual to feel where that handle is. Other indicators, like on this basket, it's an in-progress basket, and also the classroom chair, just the use of some brightly colored yellow foam, so you have a tactile and a visual identifier, so the child or the student can identify their belongings and what's theirs within an environment. Next slide. Here we have some other tactile graphics. On the left, we have real objects such as a bowl and a yogurt cup. These were actual objects that our student uses, and we have taken parts of those real objects and made them into the object cards to go with his calendar system. And with that, it's very important that you use real objects that are relevant and meaningful to the student so that they can make that connection between the objects that they use and the communication system that they use. And also, that's another thing about working with the family and parents. You know, these items here were provided by the family so that we could make the cards. And as well as, not only do we have these cards at the school, but also they're used at home. So we're crossing the environment with the communication system and the child being able to have a broader conceptual learning experience and providing them more opportunities. Also with the tray, we've taken part of the tray divider, and it represents a tray that the student would work off of. And on the right, if they're doing daily living skills such as laundry, you can use a basket handle from the laundry basket to represent it's time to do laundry possibly, or fold clothes, or whatever you designate it to be. Next slide. And again, here we just have examples of work trays and dividers and how you can make them visually accessible, either with a white or putting in black construction paper so that you have a lot of contrast. The dividers are there so that you can give choices between 1, 2, 3, up to 4 items as well. And also the trays have lips on them, so when you put items on it, they don't roll away. They stay in a confined area for the student to be able to locate them. And it makes it much easier for them, especially if they have restricted movement in their arms and in their hands. On the next slide. Functional aids, the one on the left, the laundry trolley. If you have a student who is mobile, but they have issues with being able to bend over or look down safely because of vestibular issues as well. A laundry trolley can be used to lift up a laundry basket if that's part of their daily living goals, is to do laundry. And on the right, we have an aid such as a folding board, adapted spoons for eating, what we call a sequencing board, but a board that you can use for anything. We have, it's magnetic, so we can make the object cards for our student to be able to put up there and to do sequencing of routines, such as meal prep or even the laundry routine. Okay, next slide. And here there are just more tactile identifiers on the microwave. And again, I said if you're doing it at school, try to reproduce it at home, such as using bump-ons. Also, paper shredders. You can use the red masking tape or duct tape, bump-ons to help them find the start or the power button. And on the far right, we have a paper shredder with a homemade paper guide for dropping the paper in. And I call this the cone. And it's just made out of cardboard. It's just a homemade rigged contraption that just helps give our student better access to an activity that he enjoys doing, which is shredding paper. On the next slide. And Krista earlier talked about an assessment, about the sensory learning assessment, where you can learn about students, their likes and dislikes, and they also call them appetite items if there are things that they like. These are some sensory items that a student of mine really enjoys. And these sensory items are things he likes to interact with that make him happy. They bring him joy. They also are calming to him. They're familiar to him. And you also notice they're very highly contrast and different in color. So, and he really enjoys light. So we have the book light and the flashlight as well. But these are items that we have that are available to students during the day. So if they need a break, a sensory break where they can have some quiet time or calm down, or they just need something familiar to them, that these items can be used with the student as needed throughout the day. Next slide. And I believe lastly here, we just have some pictures of individuals having accessibility to literacy. Top left, the use of the iPad. You know, the saying nowadays is there's an app for that, and there's an app for everything from reading to games, and for students with cortical visual impairment. The iPad is just a wonderful tool, or any kind of tablet's a wonderful tool. We also have a closed circuit television in the top middle of a student using it to access textbook materials. And on the top right, I have a student here. He is legally blind. He has light perception only. So he enjoys using the On the Way to Literacy books from the American Printing House for the Blind. And we pair the stories with actual items from the book. So you'll notice there is a teddy bear because the story is That's Not My Bear. So we use objects paired with the stories. In the bottom middle, we have an example of just a low vision magnification device that a student may use to be able to magnify and enlarge print if needed. And on the bottom left and the bottom right, I have made some manipulatives to go along with stories and songs for literacy. Since my student here is legally blind, on the right, he likes Pete the Cat, but he doesn't have the visual ability to look at the Pete the Cat books. So I decided to make it tactual for him. And this is an interactive way to use manipulatives where you can take something from the story and you can make it tactual where they can interact with it. So you can take buttons off for Pete the Cat and his 4 groovy buttons. And on the bottom left here at Christmas time, we're just using a tactual tree and presents to talk about counting skills and tactual discrimination.
We're over here, even Marcy and I, as teachers of the visually impaired, are just so in awe of all the fun things that Claire does and makes. We're going to go through just the role of some of the team members on the IEP or IFSP team. Just briefly give you an overview of what the roles are and what they need to do. Parent guardian is always first, but we are going to get into more detail with Katie and myself later, so I'm going to hold off on that one. The child. If they can't attend, it doesn't matter how old they are, they should, and they should be a part of that process. For some of my younger kids who were not necessarily in the meeting, I would talk to them ahead of time about something that they might want to learn so that I could include it in terms of their present levels and their goals. After the age of 14, the child should always be invited and should attend. If the child does not have, again, proficient communication skills, there are different ways they can represent themselves at an IEP meeting. At conference, you may have seen photo stories by Donna Carpenter. That's a wonderful way to show different kind of personality traits and things of a child and just make them human to the team and not just, again, those silos. And then, you could also just do interviews with a student or pictures, or they could share themselves in many, many different ways. The general education teacher will be on the team. If the child is in a gen ed setting, they'll be the primary teacher or case manager for that child. And some of these titles may be different state by state, just so you know. And then if they're in special education, the gen ed teacher will be there to provide information about access to the general education curriculum. So they're usually just kind of a different perspective on the team. The special education teacher will be in there if that child is in a special ed setting. This will be, again, the primary teacher of the meeting if they're the one who is serving the child the most. They'll serve in the same capacity as that gen ed teacher in terms of providing information about the unique needs of the student and how they're accessing the curriculum for their needs. And so this may be an alternative curriculum. It may be a modified curriculum depending on the needs of the child. The next person you'll see, and they're usually referred to in the meeting as the LEA, the local education agency representative. This is typically an administrator of some sort, and they are the one that's going to make sure that the plan is followed in terms of when you're developing the plan, that all the law components are in place and that we've met all of the legal needs. And they may be part of the organization component as well. They may be sending out the invites depending on the school system and depending on how that's set up for them. Anybody who's serving the child should be at the meeting. So in school settings, if the teacher is seeing a teacher of the visually impaired, a speech language pathologist, an occupational therapist, a physical therapist, any of those areas should be represented at the meeting. And if they are not, they usually have to say ahead of time that they can't attend and get parent approval to not attend. There could be counselors. There might be somebody representative of an assistive technology assessment. So there may be a lot of variety. There may be people that are not always there, but they are there for that particular need for that year. I'm trying to see if there's anything else. And then the outside agencies. And so this may be if this child is served by any agency outside of the school system. So like when I was in Florida, I worked for a nonprofit company who served kids who were over the age of 14. And so I knew most of those kids for years on end. And so at that, if the parent wanted to, they could invite us to the meeting. So any of those kind of, vocational rehabilitation, so job placement, the Department of Disabilities and Special Needs boards. So that could be the people that kind of look at the waivers and all of the other components for the state. It could be the Parent Training Information Center that you've invited. It could be disability specific groups. So if you have a child that has a peroxisomal disorder, you may ask for a representative from the GFPD to help you at the IEP meeting. And these people are there to kind of provide extra input about systems or things that are unique to the child or different opportunities. So vocational rehab may say, we've got some jobs opening or some work labs here that this might be a good fit for the child. So they're going to provide some of the extra outside information. Then we have the deafblind intervener. Now, not all teams will have a deafblind intervener, but if it has been deemed appropriate for your child to have one, this person provides access for your child that is unique to that child. And so they're going to be trained in your child's communication and access needs, and they are a valuable member of the team. They're usually the one that spends the most time with the child during the school day. And so they're going to provide input about the student's needs. They're going to help in making accessible materials, and they're going to facilitate communication and access for the students and others in their environment. Access is the big key for an intervener, especially for the unique needs of our kids. So they should be at the IEP meeting as well. Then the family has the right to invite anybody who they feel like would be beneficial to be at the meeting, whether that be somebody who'd be part of the educational programming, whether it be some outside people that are part of the child's life, so private therapists, if you need an advocate or a lawyer, another family member who maybe just is there to provide not just support for your child, but support for you. I think Katie will touch on this, but sometimes it's the parent and then 20 professionals at a table. And so sometimes it's nice to have somebody else that's on that family side also. And then additional notes are just things like there may be different names. If you're under an individualized family service plan, an IFSP for younger children, you may have a service coordinator and a family trainer as opposed to a case manager and a teacher of the visually impaired. So there may just be different names for those team members, but the setup is pretty much similar.
Okay, this is Claire again, and I'm going to briefly talk about the role of the teacher of the visually impaired. And from our earlier poll, I saw that I think we might have several, if not the majority of teachers with us today. So I may be telling you what you already know, but maybe I'll just say it in a different way and you'll learn a little bit more from it. But what is a TVI? A TVI is a teacher of students with visual impairments. We also have several other titles that can be used, such as teacher of the visually impaired, the TVI, vision specialist, VI teacher, or sometimes the vision itinerant teacher. And just to give you a little story, probably about early 2000s, I was teaching at an elementary school and they came to me and wanted to put me in the yearbook with all their other teachers. And I said, that's great. So I wrote down my name, wrote out teacher of the visually impaired, gave it to them, when I went to have my picture taken. The yearbook comes out and there's my picture, me smiling, and under it, well, back then there was this terminology still going around where we use visually disabled. So they decided that teacher of the visually impaired was too long of a title, so they labeled me the VD teacher. So that is now a title that I get to live with. It will go down in history, but one that I'm not too proud of having. So on the next slide, Krista, next slide. Thank you. All right, so who are we? TVIs are certified professionals who work with students who are blind and visually impaired, multisensory impaired, including deaf blindness. This certification requires a 4-year bachelor's degree and a master's in visual impairment. We have the primary responsibility to provide specialized instruction and services to meet the needs of visually impaired students. And this is from the ages of birth, or excuse me, the ages of 3 to 21. But this certification allows us to work with this age range, but doesn't necessarily mean, depending on the district or the area that you live in the United States, and how many TVIs you may have in a county, you may work with a certain population based on your specialty or what the needs are of students. And we possess the skills and abilities necessary to provide and coordinate this specialized instruction. So my instruction has provided me skills in being able to teach reading and writing of Braille, low vision devices, assistive technology, and various other specialized aspects that not the normal, regular, everyday classroom teacher would have. Okay, and what do we do? There's a lot of these here that we've got listed that we've already discussed and talked about previously, so I'm just gonna kind of go through this quickly for you. We interpret medical reports, conduct specialized assessments, and review the results with the school team. Those were all the assessments Krista talked about, with the functional vision assessment, media literacy, and the sensory learning. We make recommendations pertaining to instructional strategies based on the students' learning styles, materials, environment, accommodations, and any modifications. We also participate in the IEP development and implementation of the plan, and provide ongoing observations, whether it be in the school, possibly out in the community, and sometimes at home if you're able to get there. The next slide. We address goals in the natural environments, such as the home, community, and the school. An example of this is just like with my student who's a deafblind student. He uses a object card calendar system. So I have goals written for him to be able to identify these cards and be able to sign what they are. But also that crosses over to the home environment, because a lot of the cards that we use at school, he uses at home. Some of the ones that he uses at home, he also uses at school. So we make sure that these goals can address all his needs, not only in the educational aspect at home, but daily living as well. We also progress monitor goals. We take data, lots and lots of data. And then we are able to communicate with caregivers, classroom teachers, the related service providers, adult support personnel, administration, and the outside agencies as well. We communicate and collaborate a lot. And if you don't have good communication skills when you first start working as a TVI, you will after several years, because it's a lot of what you do. Provide instruction and or consultation to address areas of the expanded core curriculum that the student has the need. And of course, that would be based off of the assessments that have been that you've already conducted. Next slide. And the fun part of my job is I get to adapt, create, modify, and provide materials and equipment. And as I showed you my Pete the Cat, there's lots of materials that we need to create in order to modify a student's access to the curriculum or just to their environment. And that's just the fun part of it. I get to use my scrapbooking skills and my imagination, and just to work with others who are also very inventive. We provide consultation, collaboration, and training for parents, staff, and related service providers. Again, we collaborate all the time, working together, and we participate and facilitate regular scheduled team meetings that communicate outcomes of instruction. And again, to me, that's very important. Instead of waiting to the IEP meeting, annual review to discuss what works and what doesn't work, we do it more often. And we're going to talk about that, hopefully get to that shortly. Provide information regarding resources, services, and agencies.
Okay, and I know we're running short on time. I think Katie put something in the chat box. We're going to try to keep it moving along. So really quickly, I'm just going to address the professional view of the family role, and then I'm going to have Katie give her perspective. But basically, to me, this is the most important part of the meeting, or the most important person in the meeting. They know their child in and out. They can speak to their child's strengths and what their needs are in environments outside of school, which is really important because as a young TVI, I found out that I was wrong most of the time if I doubted a parent. And as soon as I saw that child outside of the school environment, you could see exactly what the parent was talking about. And so I learned early on to check my ego at the door and know that my parents are my experts. They provide all the background information about the health needs of a child. And that's really, really important, especially when we talk about some of the things that Claire mentioned, environment, things that might set off a seizure, medication that might make them drowsy. Those kinds of things are really important. They provide input into the assessment and into the services that we provide. And so I couldn't do any of the sensory learning assessments without parent input because they really talk about what the kid likes at home. And that's really important. Making sure that a family is considered a valued part of the team is really important because that means that you might see the follow through after school. If they're as much included on the team and making goals, then you get to see that across the board, which is what we really want for a kid. They're going to help prioritize those needs. So if the team says, well, this child, needs to work on these functional Braille reading skills, and mom says, but I need him to be able to eat and toilet, that's going to take precedence because that's important for all of life. And then they can also request any kind of assessments or pre-planning information. So if the IEP is coming up and you want to know what page the team is on, you can say, hey, can you guys send me some information about what you guys are thinking for the IEP before we get there? So you're not blindsided when you get there. And you have the right to ask for that information. I'm going to move this on to Katie.
Hey everyone, I really do exist. I'm going to pop out of host mode for a moment. And many of you know I'm a parent to a child with deaf blindness and multiple disabilities that is caused from a peroxisomal disorder. So the image on this screen is one that, it's titled Outnumbered. And on one side of the table, you can see it's filled up with people, which are clearly all of the professionals. And then on the other side, there's two people, which is to represent the parents or a parent and an advocate in this case. And while sometimes, I've shared this so many times, and we can look at this and we can laugh and it can be comical, but it's a real case scenario most of the time when you walk into an IEP meeting. And team meetings can just be so overwhelming. I remember back to my very first IEP meeting, and it was over 17 years ago. And I still remember to this day the room and where I was sitting. I remember us having to take a break so that I could step away and pull myself together. I was not prepared at all. Since then, I've literally lost track of the amount of IEP meetings that I've been in, and that's for my son and others as well. So as the saying goes, I wish I had known then what I know now. And this image, I know now, it doesn't have to be that way. It doesn't have to feel that way. You do not need to do this alone. Bring your tribe along. I know some of what I'm sharing right now is a little repetitive, but we're saying it again and again because it's so important to know. You can invite anyone to the table that you feel can contribute. Who has knowledge about your child? It doesn't have to be an attorney. It doesn't have to be a formal advocate, although they are very helpful. It does not have to be. Anyone who knows your child can be valuable to the team. So you get to decide this. You get to decide who comes and who is invited. We talk about bringing in other professionals and outside agencies, but don't forget about your own family members and friends. You can also ask a family member or friend to come along and take notes for you. Taking that off of you so that you can have your primary focus, your sole focus, be listening and participating and being a full active member of the team, that can be incredibly beneficial. Whoever you choose. I know for me, I started a few years ago. I now have 3 or 4 people attend meetings with me, and it has been such a positive shift when I stopped and asked other people to help me. So be an active team member. Your role matters. And next slide. Thanks, Krista, for helping out with that. So on this slide, I chose a picture of a bridge because I believe parents very much are a bridge for our children. We connect home and community and school. We are their one consistent person who's everywhere. So we really can bridge this. Yes, share your concerns. And you're going to hear me, if you know me well, you're going to hear me say, share your concerns and document them. But there's so many other things to share too. Share what works, what motivates your child. Share your child's likes and dislikes. Share their struggles, share their successes. Ask questions and ask, for ideas. Ask for training. Ask for training for you. Ask for training for your team members. Ask for training for everybody. Yes, as parents, we are going to know our child best. I always say, I feel like I am the expert in my child. I have a lot of information to bring to the table, but I don't have all the answers. I'm not going to have all the answers. I, as a parent, do not have the expertise that all the specialists sitting at the table. We all have our role. So share with them. Your examples and your stories can be really powerful. We talk about puzzle pieces, and I feel like we often fail to realize just how significant the pieces that we parents carry really truly are. Is your child on a new medication or not sleeping well because of apnea or some new reason? Vision loss alone can cause sleep pattern issues. Many children, just like mine, have different abnormal neurological activity. And so that can cause a difference in how they're functioning from day to day or throughout the day. Something as seemingly simple as not sleeping well can help the team fully look at the child. Is your child having outbursts or getting upset every day after lunchtime when they've worked, when they're asking them to maybe help clean up? And so if you stop and think about it, I think a lot of professionals may stop and say, oh, maybe they don't like the rag or the sponge. It's a tactile thing. Or they may say, oh, they don't like the motion, or they just don't like cleaning. But you may be the only person that can come in and be able to share that cleaning chemical reminds the child of a hospital smell, and that it's actually triggering memories that are pretty horrible. And so you bring those pieces. Nobody else at that table is going to bring that piece. Additionally, think of the lighting at school. It's bright. We talked and shared all these accommodations and modifications that are in place. A lot of professionals are seeing our children in a very controlled environment of a well-lit classroom, for example. So I was the first person as the parent that was able to identify a change in my son's vision when it was declining a few years ago. These are only a few examples of the wealth of information that I know is endless that us parents have. Remember Claire talking earlier tonight, I'm so used to doing webinars at night. Remember Claire talking earlier in this webinar about seeing the person as a whole person. And we can't do that unless we have everybody contributing and sharing. In this picture, you're going to see a table full of papers, laptops, hands, and arms, and they're all reaching towards the center, towards various items and materials in the center of the table. That is my son's team. And that is a few of us working together. We're actually feeling the different textures of the materials. We're creating language. We're working together to combine our experiences and knowledge to help the student be successful. This did not happen overnight. This requires work. There are stages, and teams work at varying levels. Actually, the same team will go through different stages. And that's going to change even as different professionals come in and out, and you have different people on that team. So coordination sounds great. Coordinating services, we think about bringing in the outside agencies and everybody coordinating, but that doesn't even fully allow teams to think outside of the box. Research demonstrates that actual collaboration, that stage, is the kind of teaming that is the best outcome for students. Collaboration requires openness to new ideas. I believe Krista already mentioned this. Egos must be left at the door. Collaboration requires a way of thinking and relating as a contributing team member and not an individual expert. And that's part of what I think we're doing here today. We're stopping and we're identifying and we're trying to understand each other's roles better. Parents, you are naturally the bridge that extends into all areas of your child's life. This helps bring everyone and all information together. So always remember that you are a valuable piece of this team.
I second that. We're just going to quickly, we've been talking about IEPs and IFSPs, so just quickly addressing the difference between the two. The IFSP is the Individualized Family Service Plan, and that is exactly how it sounds. This is for our early intervention kiddos. So this is birth to 3 years old. It's referred to as Part C in the law. And this basically focuses on the needs of the family as opposed to just the educational needs of the child. And it occurs usually in the home. We do have a poll up asking if your child has an IFSP or an IEP. Right now we have a couple of answers that are 100%. I'm going to let that keep going while I explain the IEP. And that is the Individualized Education Plan. And this is from 3 to 21 years old or until your child graduates, so that age out year. This is referred to as Part B, and this specifically looks at the educational needs of the child. And it's going to mostly occur in the classroom environment or the school environment or anywhere that the school is working with that child. So the big thing to know is that when we look at the IFSP, that role release component, that happens a lot more in this area with the family. So we're looking at, like, again, the whole family as a whole. So it may even involve the siblings, parents, but that person is coming in and the family gets to kind of dictate what those needs are at that time and how the team can help support them. And we've got 83% who have children with an IFSP or an IEP and 17% that do not. I think we're winding down to just collaboration of services.
Okay, this is Claire again. So as most of us can figure out by now, it takes a multitude of different professionals to work with the unique needs of our students with visual impairment, multiple disabilities, and deaf blindness. So it takes a lot of collaboration. There are some team models out there that show how people can work together. First, a multidisciplinary team is an individual specialist working directly with the student at specific times to address IEP goals. So this would look like maybe the OT or the PT, speech or related service providers coming in, working directly with the student maybe, and then leaving. Transdisciplinary team are specialists working through a main teacher who implements the recommendations through daily routines in a functional setting. And this is most popular here in the United States with public school settings. Specialists will come in, maybe set up a plan, give recommendations, set up things, but the plan is for the classroom teacher and staff to implement these activities and what the student has learned through daily routines or daily practice. And an interdisciplinary team is specialists working with the student and collaborating with each other often to develop a single plan to meet the student's needs for services. And this would involve people coming in, working with the student, as well as role release, like what Krista was talking about earlier. The classroom teacher following through with daily routines, and as well as collaborating with outside agencies. Maybe the PE coach needs to be involved for certain things when it comes to physical education, and as well as maybe your deaf-blind project if you have one in your state. Next slide. And there are some key points here that I want to make when it comes to team models. Most teams use a combination of more than one model at a time. And think about the example I gave you earlier with my student TJ with deaf blindness. I do go in and work with him directly weekly, but I also consult with everybody else who works with him. And we all meet together on a regular basis and discuss what's working and what doesn't. So we use a combination of all these models in order to meet his needs. And then this key point number 2 is following a specific model is not as important as having an understanding with team members and family about how the individual education plan will be implemented and who will be responsible for what parts. So how will goals be implemented and who will be responsible for documenting and supporting each goal? And as Krista talked about before, you can have shared goals between related service providers. Myself and my SLP with TJ, we both have similar goals and work on similar things, and we consult with each other on the data that we're collecting to make sure that our student is benefiting from both of our service, because sometimes repetitive service is a benefit for these students who need repetitive practice. If communication is a need, who will be part of the communication team for brainstorming ideas for devices, vocabulary development, signing gestures, visual and tactile considerations? What about the creation, the adaptation, or maintaining of materials? You may have to have specific people who are creative and like to cut and paste and come up with ideas for those types of activities. And those activities aren't for everybody on the team. Can you meet on a regular schedule to review what's working and what is not? And again, I emphasize that waiting till every 12 months for an annual IEP meeting is not enough time, it's not enough. All right, next slide. And just examples of these types of what I call sub-teams. You have your IEP team. Now we're talking about sub-teams. If your student has curriculum needs, such as, what are they going to do the regular curriculum that's in the special ed classroom? Or are they going to have a modified curriculum? What's it going to look like? Well, not everybody on the IEP team needs to be involved in making those decisions, but you might have just a few who could help with that with their area of expertise, such as a classroom teacher, the vision teacher, speech, adult supports like the deafblind intervener, and parents and caregiver. Same with communication needs. If the student is going to have to use an alternative mode of having access to their education that's not print or large print, what if they have to learn Braille? What if you're going to use a tactile system or an object card system? Who's going to be on the team to help with that? Also with assigning, coming up with needed vocabulary. So you would want to include the classroom teacher, the deafblind interveners, vision, speech, hearing, possible administrators within the building, OT if you're thinking of tactual considerations, and of course, again, the parents or caregivers. And lastly here, another example is mobility needs. Here we would want to include the classroom teacher, the DBI, physical therapy, O&M instructor, vision, and possibly the PE teacher and parents and caregivers. So every student's team may be different depending on the needs of the student and the needs of the family. Next slide. And to end on just an overall note of coordination and collaboration of services, we have a Venn diagram here that just shows you how all the different services kind of come together and how they overlap, how they work together, how collaboration can all work together, including those outside agencies who may come in every once in a while, community, counseling, extracurricular activities, how they can all be integrated where appropriate. But as you notice, the student is at the center of this, and everything is working around and for the student. And through proper communication and collaboration, your team or sub-teams will be able to provide an optimal opportunity for your student to learn. The end.
Thank you, Krista, Marcy, and Claire, so much. And to everybody who's listening in, thank you for sticking with us. I know that we went way over, and I apologize for that, but this was such great information. Thank you. Thank you so